Thank you very much. Thank you for your introduction. Good morning, everyone. Dr. Sang-Ho Kim, thank you very much for inviting me once again. I will try to combine two subjects. One is fusion imaging, that what you asked me first to present, and then to try to find benefits of not only this way of imaging in the cath lab. So. Once again, thank you for inviting me here again. I really enjoyed my previous visit to South Korea. It was very fruitful, and that was very busy meeting. So it is very different from many other meetings, and I kind of get this magical ingredient of this meeting. Currently, we have plenty of imaging modalities that we can use in cath lab to make our interventions either more successful, more efficient, or safer. I will not go through all of them, so don't worry. I will focus on the top three, which I regularly use in the cath lab. So here you can see rotational angiography, where we actually build 3D models in cath lab using simple two-dimensional angiography. Fusion imaging, mostly with computed tomography and magnetic resonance, where we actually use pre-registered data sets, and then we fuse them, register them with two-dimensional fluoroscopy. And finally, virtual reality. That doesn't necessarily happen in the cath lab, but it gives you great insight in three-dimensional anatomy before you bring the patient in the lab, or sometimes during the case when, for example, we obtain rotational angiography. We put our goggles on, and then we use that three-dimensional data sets to make plan for the intervention or to assess intervention. But in order to understand three-dimensional imaging in a cath lab, and specifically 3D fusion, I just want to take you through 5 steps, which I think are crucial for better understanding and better decision-making in cath lab. First of all, you have to buy into the idea. You need to have software and hardware. Then you need to have data sets, whether CT, MRI, or 3D array from previous study. Knowledge and skills are also very important. And finally, you need to understand limitations. If you know all that, you can take it to another level. So, first of all, 3D imaging in cath lab is about nice images. We can have beautiful two-dimensional images, several projections, several angiographies. That's the usual way of imaging in cath lab, and this is the gold standard, but it's still two-dimensional imaging. So, like in this example of coarctation stenting, what do we do when we have this patient in the lab? We first of all have to perform at least 2 projections, 2 angiographies. Then when we introduce wires, sheets, we have to perform a positioning of stent. After stent implantation, we again have to do at least 2 injections or at least 2 projections to assess outcome. And you know, sometimes it doesn't work that fast. Sometimes your first angiography isn't the perfect one. So you need to find a different projection, maybe different angle. Some structures can be foreshortened. There may be overlying structures. So altogether, angiography can be a simple thing, but not necessarily in all patients. So if you take it to another level, higher level with rotational angiography, you already at the beginning gain many images, many projections, and you also have dynamic information. So you can take measurements in systole and in diastole, which is important for some interventions, for some coarctations, but even more so for percutaneous pulmonary valve implantation, where you can have different sizes in systole and diastole. So from that rotational image, well, you can use this one to make a decision about treatment, but you can also use the 3D reconstruction. And this is done by software. You have to manipulate it. You have to cut something out, or maybe use different settings to have a better image. But look, you gain a lot. You gain those projections that are not doable with regular angiography. For example, you can look from the top of the patient, which is very important, maybe for correctation. But for example, if you have TGA patient after arterial switch, and you can see that these pulmonary arteries, they splay around the aorta. So in some projections, they don't look narrow. But when you look from the top, you're going to find out that they're very narrow. So rotational angiography might not show that, but 3D reconstruction, yes. And then you can use that 3D reconstruction to guide your intervention. And this is done automatically with rotational angiography. And you can use that roadmap to guide your stent positioning and stent deployment. Finally, you can perform one more rotational angiography, and you have plenty of images to look at the position of the stent. You can measure dimensions of the stent, and you can gain even more information from that 3D reconstruction. Well, but these three-dimensional rotational angiography in the cath lab actually does take some time. You have to set up your C-arm, you have to do test spin, you have to dilute contrast, you have to communicate that with your staff, you have to have anesthetists on board, because for all rotational angiographies we do it with apnea. So you have to get people involved. There are many benefits, but one of the significant limitations is that you have to do that post-processing when the patient is on the table. So think about it. You do your angiographies the usual way. What next? You want to have measurements, and then you tell your nurse what balloon stent you want to use, okay? But imagine now you have nice rotational angiography, two-dimensional images, three-dimensional images, and then someone, or you, if you're faster, is clicking and building the 3D model. So your nurses are waiting, your fellows are waiting, and you're probably the only one that knows what's going on at the moment. So that might be a limitation. And in many cases, in many interventions that we perform nowadays, we have three-dimensional imaging before the patient comes to the lab. It can be CT, MRI, a three-dimensional echo. So we can actually use those images to create the 3D model before the patient arrives. And then we can use it as a 3D roadmap to guide our intervention. And this is an example of correctation. CT image was uploaded to software, and this is what we get instantly. And then from that image, with just a few simple clicks, you can create a model, target lesion, the structure that is of most interest to you. And you can spin it around, look from different projections. You can understand anatomy a lot better. Still, this is on two-dimensional screen. Okay, so it's colorful, it's nice. You can turn it around, but still it's two-dimensional imaging. And then you can present it in many ways, different colors, just borders, or you can take measurements, specific measurements. Sometimes radiologists take measurements at set areas, but maybe for this particular patient you want to know something more, measure more. So these measurements don't need calibration. You can make them very fast. And you can put some rings, you can make some annotations, so you can highlight some structures. That's the most important part. The previous steps you can do before the patient arrives to the lab. But this one actually is when the patient is on the table. So you do store fluoroscopy in AP and lateral, and then you have to fuse or register that three-dimensional data set, your three-dimensional roadmap, with current fluoroscopy. And in this case, I use bony structures, which is very good for CT, and, but in other patients, other devices or structures might be beneficial. And then you move to intervention. And in this case, after balloon predilation of that lesion, I implanted a stent there. There was no need to inject contrast before that stent implantation. And contrast was injected afterwards to assess the outcome. And here you can see image from rotational angiography. So our initial experience several years ago included 34 patients with fusion imaging, where in 28 we used it for live guidance. Initially, we used it mostly for pulmonary artery interventions, right ventricular outflow tract interventions, and correctation. And the important message from that paper is that in majority of patients, we could achieve good alignment of that 3D map, but in 22% of patients, once you introduce stiff wires, catheters, the alignment might actually change. And also when you do there's a wake patient and the patient moves on the table, or you just push with a long sheath on the groin and you push the patient a little bit, your alignment might change. But overall, in over 90% of patients, we were able to use that imaging modality successfully. You might wonder, okay, so in how many patients that can be beneficial, that can be useful? And I look at 7 consecutive years at my previous cath lab, and we had almost 2,500 cases there. And obviously, for not every case, you need 3D imaging. I don't think for regular balloon atrial septostomy, you need that. For PDA closure, you probably don't need that. For pH study, for example, you don't need rotational angiography or fusion. So we had 1,600 patients that we thought were eligible for 3D guidance. And then majority of cases where we used 3D guidance, either 3D array or fusion of CT or MRI, were patients with pulmonary artery interventions, collaterals in single ventricle patients, correctations in right ventricular outflow tract interventions. And when you see in certain interventions like those on right ventricular outflow tract, more than 60% of cases we actually use 3D imaging. And overall, out of those 1,600 cases, in more than 500 cases, we use 3D imaging. So it's like 34%. We started at 28, then we went up to 34. But this is key message. It was really dependent on the operator. So it was dependent on the fact whether the person in charge actually bought into the idea of using 3D imaging. And there was one person that used it only in 13% of cases, whereas another operator used it in every second case. So I guess this is also important, your attitude towards it. And then to combine our single center experience, I invited several centers to share their experience, including Sengho's hospital and his center, and center in Berlin, Mexico, and US. So we got together over 200 patients, and 182 patients we use it for actually guiding cardiac catheterization. And just a few thoughts from that research. First of all, the alignment of the 3D roadmap with two-dimensional fluoroscopy, which I told you was crucial for that type of imaging. You can see that it was either accurate or there was minor mismatch in majority of patients at the beginning of the study. And when we introduced our stiff equipment, the alignment, proper alignment, was in 90% of cases. So still in 10 out of 9 cases, even if you go with a hardwire, you can have accurate alignment. Then this is a true like blueprint for me, whether someone really believes in that imaging. The fact if you just used 3D imaging and no contrast, no additional contrast, which means that actually you have proper alignment and you really believe in what you have on the screen. And you can see that overall, over 20% of cases were done without prior contrast injection. So all that imaging that was done before bringing a patient in the lab actually translated into interventions without contrast. Contrast was injected to assess outcomes. And Another important thing is that when we ask operators about usefulness, you can see here that overall 98% of operators in 98% of cases, it was thought useful, very useful, or in some cases even essential. So that shows that many operators actually can find benefits beyond pretty images, and in some cases that type of imaging in a cath lab brings additional information. However, fusion imaging is not only about nice pictures. Now I'm going to give you some examples that it does bring objective benefits. This is a paper from my previous center when we looked at 3D guided ductal stenting in hypoplastic left heart syndrome, and we compared it to regular two-dimensional angiography. And in our experience, in our hands, when we use 3D imaging, patients received lower radiation dose. The group in Germany looked at their experience with rotational angiography for correctation stenting, and in their experience, when they used 3D overlay, they had lower radiation dose and they had shorter fluoroscopy time. So back to Poland and to my previous cath lab, where we looked at percutaneous pulmonary valve implantation, these balloon expandable valves. And I compared regular standard 2D imaging, 3D array, and CT and MRI overlay. So if you just look at any type of 3D imaging, when you compare it to 2D imaging, radiation dose gets down. So that's the first benefit for our group. If you look at fusion of previous three-dimensional imaging, you get not only radiation down, but you also have lower contrast usage, and you also have shorter fluoroscopy times. So once you learn how to use it, you can do cases faster, you can have less contrast and radiation exposure. This is combined experience from Poland and Mexico, looking just at coarctation. And in this, for this particular intervention, this particular lesion, we were able to get statistically lower contrast exposure, contrast usage, and there was tendency for lower radiation exposure when we used fusion. And again, another group from Europe, they looked at their fusion of CT and MRI for different interventions. And in that group of patients, they had significantly lower contrast, radiation, and also fluoroscopy time. So in experienced hands in many centers, it's doable, and you can also achieve objective benefits. Well, you need to have certain hardware and software, and I'm not going to go through these examples. You just need to ask your vendor and ask for specific information, but currently all vendors provide at least one and some even two fusion imaging platforms. For data sets, I showed you some examples of using a previous CT and MRI. This is most common that we use for fusion, but let's say you do 3D array today and you perform some intervention, and 2 years from now you bring the patient back to the lab, you still can use that three-dimensional rotational angiography as your roadmap. And then knowledge and skills. There have been several focused meetings on 3D imaging for cardiac interventions. And there were 3 in Europe, in Netherlands, and then several meetings in US. These meetings then joined other meetings, and now they work as sessions on big interventional meetings. And I guess there you can find information about how to use that imaging, and a lot of information there. Recently I had this pleasure to work with 2 actually medical physicians to write this chapter, and I encourage you to read it. Not because I wrote it, but because there are 2 actually physicians, medical physicians that have different perspective on 3D imaging and fusion. So this gives you a much broader insight into how it can work, why it cannot work in certain patients. But let's say you want to start a implantation of new valve. So what happens at the beginning? Not only that valve comes and is brought by a company to your lab, but also a proctor comes to your lab. So I think it's also a good idea to ask your vendor for some specific training and proctoring. Imagine that angiographic systems are much more expensive than, for example, stents, valves, or occlusive devices, yes? And proctoring, it's the way that people acquire new techniques and bring them into their labs. However, for imaging, 3D imaging is not that popular, but it depends on you. If you ask your vendor, they should provide you people with experience in that software. So just to go through a few examples of fusion of CT and MRI, this is the most important moment, registration, and I cannot really overemphasize that, because if you do it well, then it will save you a lot of hassle during the case and it will make it much more safer and effective. Whenever I have multiple landmarks, I use them. So like here, cardiac silhouettes, bony structures, calcifications, previously implanted devices, even airway. You can use airway to register. Well, whenever there is nothing to register with, you can use a small hand injection of contrast, and that still can be helpful. But the best way is to combine as many internal markers as possible. During a case, you need to be aware that when you introduce equipment, the alignment can change. But if you use a regular catheter and it goes through the tiniest segment of the aorta, it means that you have proper alignment. If the wire aligns to the outer curvature of the arch, again, it's a proper alignment. And if you have a small patient and you use soft equipment, that can also help you to confirm that your alignment is accurate. This is interrupted aortic arch that came to cath lab with previous CT imaging for ductal stenting. This is how I'm building a 3D model, and now you can see that model overlaid on fluoroscopy, and look, that wire will not distort anatomy. That's a soft wire, and it goes through RPA, now through the duct to descending aorta. On lateral, it goes to left subclavian. So it means I have a proper alignment, and then I can use these two blue rings as a landing zone for stent implantation. This works for soft equipment. This is another example of my collaboration with Colorado Group, where we used wire curved in the ascending aorta. And you can see there's a wire there, and without any contrast, any other markers, we can align that 3D reconstruction, that 3D roadmap, with current position of aorta, and then use it for transverse arch stenting. This is an example of tetralogiofollow patient with hypoplastic left pulmonary artery that came to the lab for LPA stenting. This is a CT image and reconstruction with two rings indicating our stent landing zone. And in a moment you'll see that in this case I use bony structures for alignment of that 3D data set with 2D fluoroscopy. And here you can see soft wire goes directly through the rings, but if you use stiffer wire and you put a little bit of a tension, it shifts slightly upwards or headwards, but still it's useful for precise stent implantation. You can have the entire 3D volume exposed, visualized, or you can just have rings there. Well, I encourage you to be creative with using these software, these tools. Several years ago, when we started with 3D array, we didn't have many tools except from cut. So we could cut either outside or inside. There were no marking points, no rings. So to create a model that would lead stent implantation, guide stent implantation, I decided to leave left pulmonary artery here. Here, cut out slice where the retrograde aortic arch originates. And so at the end, I have this model, and I can use it as an overlay to guide stent implantation in arterial duct. Sometimes patients come to the cath lab with CTs, but they're of poor quality, and we never really ask for extra CT for fusion. We just used what's available. And in this case, patient after single ventricle patient after second stage, you can see that there is a poor opacification of proximal, especially here, left pulmonary artery. So what we can use are rings to annotate where is the beginning and end of stent landing zone, or, for example, left main bronchus or native aorta. So another structures that are important for that intervention. And in this case, bony structures again used for fusion. And once that is optimized, you can see that 3D model being used for stent introduction and stent implantation. Okay, so you can have pretty pictures, you can have objective benefits, but you have to understand that there are some limitations. This is example of very clear limitation. This is patient with pulmonary atresia, major aortopulmonary artery collaterals, CT scan manipulated to project and to highlight those collaterals in native pulmonary arteries. And when the patient was brought to the lab, it turns out actually that there is time between the moment when CT was performed and when the catheterization was performed. So the patient has grown, and obviously you cannot use that CT. And you have to bear in mind that this is not a real-time modality. So you have nice alignment and beautiful 3D roadmap, but when you introduce stiff equipment, situation can change. And look here, this is a soft wire, this is just catheter, and this is a stiffer wire to later introduce a stent. So my colleague used this wire, and then he told me, oh, it doesn't work. Of course it doesn't work, because this CT was performed without wire inside. And during the case, you introduced a stiff wire, so you're going to change anatomy. So this is the key limitation of that technology. If you have mastered all that, let's take it to another level. Okay, so bear with me for a couple more examples. And I would highly encourage you to mix and match 3D imaging technologies. And I'm sure that in all your hospitals, you do have several to choose from. So you can fuse not only on the table 3D with 2D, but you can use different imaging technologies. This is example of percutaneous pulmonary valve implantation when we use MRI fusion with fluoroscopy. But to assess coronary arteries, we perform rotational angiography, where you can see the distance between the coronary artery, the balloon, and the valve ring. And finally, after valve was introduced with assistance of vessel navigator with fusion imaging, the final outcome was assessed with intracardiac echocardiography. So if you bring in another modality, you can decrease radiation and contrast exposure. This is a 6-year-old patient with arteriovenous fistula in the right neck region, and I used this CT scan to fuse it with 2D fluoroscopy. And I'm coming here from the venous side of that fistula, and I placed a device here. And so this is CT fusion with fluoroscopy. And finally, a colleague from radiology performed ultrasound, so there was no contrast injection after that intervention, just ultrasound of the neck region to confirm device position and also flow in that region. This is example of balloon aortic stenosis dilation without contrast. MRI scan was manipulated to highlight the level of the aortic valve, to take measurements of aortic valve, and then wire in the aorta was used to align that 3D roadmap with 3D model. And then during the case, you can see that the indentation on the balloon more or less correlates with the position of the aortic valve, and there was TEE to assess outcome in that patient, so no need for contrast injection. This is an original paper from my Polish group where we looked at stent implantation with fusion of CTs and MRIs. And we just want to highlight here that we were able in selected patients to actually place stents without prior contrast injection. I'm not telling you that to convince you that that's the way to do. I'm just saying that if you really believe in it and you do it in a proper way, you can have accurate alignment and you can place stents or devices without contrast injection. This is not for sport, not for fun, but it does bring some objective benefits to our patients. When I went to Krakow to a new cath lab and they asked me to build a team there, so this is one of the fellows that wanted to work in a cath lab, and I tried to explain to her 3D anatomy. So try to correlate CT image on a flat 2D screen with her orientation, and there were a group of fellows also watching it. And I thought, well, that's not the way to go. We have advanced imaging technologies. So a couple of years later, we introduced virtual reality to planning of our interventions. So we do use goggles in a cath lab. Sometimes we use goggles during our cases. So again, this is an example of fusion or combination of different modality techniques to perform cardiac interventions. And this is a tiny baby, heterotaxy syndrome, with came into the lab for PDA stenting. This is PDA here, but also there was a restriction at the intra-atrial level, and I was trying to figure out how can I get to that atrial septum, and it turns out that our fellow came with this virtual reality reconstruction, and on green you can see actually that there is communication from SVC through left pulmonary veins to the left atrium. So I could use that communication actually to go to have easier way from left-sided SVC through that vertical vein and down to the left atrium. So I didn't have to go upstream, I could go downstream, and that was used to guide cardiac intervention. So
Professor Goreczny, we are very behind the schedule.
Okay.
Could you conclude?
2 more cases, thank you. So no 3D imaging for this particular patient in the lab, but nice imaging before. Okay, this PDA stent, initially PDA stenting, I declined that on our surgical meeting. Well, I was hesitant, and surgeon said, okay, I'm going to do it. I'm going to put a central shunt there. Well, as you can see, that wasn't the case, because in the middle of that surgery, he called for assistance, and he said, I placed a sheath for you. Can you place a stent? Pulmonary arteries are small. If you look at a projection, well, narrow, perhaps tortuous, but bear in mind, if you look at the lateral, quite tortuous there. So that's the sheath he placed for me. It was very kind of him. And then 2 stents, but unfortunately the sheath was already in the duct. So I had to go from femoral vessels to stent the proximal part of the duct. And this is an example where virtual reality was very helpful. Look at the right pulmonary artery there, squashed by big aorta, and then there is right main bronchus and descending aorta. So when you look at that, already in this screen, you can see a lot more, and you can appreciate better how this right pulmonary artery is there narrowed. But when you put goggles in, you actually are immersed in that anatomy, and you can better understand how right pulmonary artery and right main bronchus are very close to each other. So that was used to guide also a hybrid intervention with pulmonologists on site, and we used bronchoscopy, used several balloons, and then placed a stent in that right main bronchus. So this is, believe me, is my final case, okay? So bear with me for 30 more seconds. This is a teenage patient with ruptured aortic aneurysm. And these images, I'm going to click through them. You're going to see that there is that's the aneurysm there. And that's the aneurysm there. There were at least, 4 sites of contrast leak outside of the aorta. And we used this CT, very good CT, but with virtual reality, we're able to actually localize these leak points, all 4 of them, and then we planned intervention, and we took it into steps. So let me just, okay, so this thing here, we just wanted to exclude entry point somewhere in the region of the left subclavian artery. The patient came to us with a stent already in that pulmonary subclavian artery, which didn't help us, actually caused a lot of challenges. So that's how it looked at the beginning. That is how it looked after a second cardiac catheterization. Then we performed one more CT to make sure where's the final entry point. It's in that region. So let me scroll this. Okay, you see there are stents in the left subclavian artery, and we have a tiny but still leak there. And you know that the patient is on antiplatelet, anticoagulation treatment, so it will not stop on its own. So we brought the patient one more time to the lab, and that's the final outcome. So when you think of fusion, you can see CTs, MRIs overlaid in a cath lab, but you can also fuse CTs, virtual reality, with 2D imaging. You can fuse experience and skills from different teams. At this table, we had a pediatric cardiologist, adult cardiologist, interventional radiologist, and surgeon. So that's another example of fusion of specialties. So with that case, I want to thank you for your attention.